topic that we are going to from neurology is stroke. We learn about cerebral stroke, cerebellar stroke, and brain stroke. How to differentiate between anterior circulation stroke and circulation stroke as well. So, what is stroke? Stroke is a syndrome vascular origin. Stroke is basically sudden of blood supply to the brain. So whenever there is a sudden interruption of blood supply to the brain, the delivery of oxygen be stopped. It will result in focal neurological deficit. So stroke is a sudden onset of focal neurological loss that is of vascular origin and that is lasting more than 24 hours. So if the symptoms or the blockage last 4 hours, then it is called transient ischemic attack. And if the blood vessel lasts more than 24 hours, it is called stroke. If it's less than 24 hours, then it is called transient ischemic attack. Now, what you are going to do if someone presents to you with a stroke? The initial management of the stroke is, first of all, CT scan of the head. Why CT scan is important? In giving any treatment or before starting any treatment, because from CT scan we can exclude hemorrhage. So if a patient presents to you with focal neurological deficit that is sudden in onset, then the first thing that you need is to do a CT scan to exclude hemorrhage. And if there is no hemorrhage, and if there is no hemorrhage and the stroke is ischemic, then you have two options. The first option is that you do thrombolysis. What is thrombolysis? A thrombolytic medication is given, such as alteplase or strep, in the breakdown of the thrombus, leave the blockage. What is the indication of thrombolysis stroke according to NICE guidelines? If someone to you within 4.5, if the onset of the symptoms is within 4.5 hours, then initially we will give that patient alteplase. And if alteplase is not available, then streptokinase is used. The mechanism of action of streptokinase or alteplase is that it causes the breakdown of the thrombus. But the indication for thrombolysis is within 4.5 hours and CT includes hemorrhage. So if there is no hemorrhage on CT scan and the patient presents to you with within 4.5 hours, then you need to thrombolyze the patient. So this is the initial management or management of stroke. Now, what other medication that you need to? Is my voice clear now? Here.
There is distortion in between.
The distortions are due to my internet connection problem. Let me see. So the acute management of stroke is if someone presents you with focal neurological sign of focal neurological deficit, which are sudden in onset, then the first thing that you need to do is CT scan of the brain. And if there is no hemorrhage on CT scan and the patient is presented to you within 4.5 hours, then you will give LT plays or streptokinase. After that, you need to give so patient present to you within 4.5 hours, then alteplase, and if patient present to you after 4.5 hours, then what are you going to do? If patient present to you after 4.5 hours and there is no hemorrhage on CT scan, then the medication that you need to give is Disprene 300 mg. 300 mg Disprene initially. 300 mg
Yes,
Disprene
sir.
is
Can
given
you
for
repeat this again, please?
which point?
That when we are going to give this pre?
First of all, if we are talking that there is no hemorrhage on CT scan. Now it depends on the time duration of the presentation of the patient. If patient present within 4.5 hours, then alteplase. And if patient present after 4.5 hours, then Disprene 300 mg.
Okay, sir.
Disprene will be continued for 2 weeks, 300, 300 mg Disprene for 2 weeks. Then the long-term medication include clopidogrel 75 mg and statins lifelong. So, so the long-term management of transient ischemic attack or stroke include what are the long-term medication that we need to give to a patient with stroke. The long-term medications are statins and clopidogrel. Two medications need to be taken lifelong if someone has a history of stroke or transient ischemic attack. What are those two medications? Statins plus
Clopidogrel.
clopidogrel 75 mg. Now, what are the causes of stroke? The causes of stroke can be, it can be a thrombus in the carotid artery, or it can be an embolus that is traveling from somewhere else to the blood vessels of the brain. So can any one of you tell me from which location or from where, which part of the body a thrombus can travel to the brain? Can anyone tell me an example of a condition which leads to thromboembolism? A condition that can lead to thromboembolism, a
Could
heart
that be
condition.
DVT?
What?
DVT.
Deep venous thrombosis.
Yeah.
Yes, there is thrombosis, and yes, the thrombus can travel to the lungs from veins. The thrombus can travel to the lungs. So yes, in general, it can cause thromboembolism. So can anyone tell me heart condition which can lead to thromboembolism?
Atrial fibrillation.
Yes, atrial fibrillation. If someone has atrial fibrillation, then the clot can travel to three locations. Yes, the lecture is being recorded. So in atrial fibrillation, due to irregular heartbeat, there is increased risk of thrombus, thrombus formation or clot formation in the ventricles or in the heart. Now this thrombus can travel to three locations most commonly. It can travel to brain through carotid arteries, resulting in stroke. It can travel to limbs through aorta, descending aorta, which will result in acute limb ischemia. It can travel to GAT tract, the blood vessels of GAT tract, which will result in acute mesenteric ischemia. So you can see that the major problem in atrial fibrillation is the formation of clots in the heart, which can travel to brain, to blood vessels of brain, to blood vessels of limb, to blood vessels of gut. So if someone present to you with a stroke due to atrial fibrillation, then the management or long-term medication will be different. So we can say that a patient with stroke and without atrial fibrillation, the long-term medication is statins plus clopidogrel. A patient with stroke plus atrial fibrillation, then the long-term medication will be different. How it will be different? A patient is having stroke as well as atrial fibrillation, then instead of clopidogrel, we need to give an anticoagulant such as warfarin or direct-acting oral anticoagulants such as rivaroxaban, doxaban, apixaban, or dabigatran.
Sir, could you just repeat the different parts of the body that atrial fibrillation could affect?
Yes, in atrial fibrillation, clots are basically found in the ventricles. So from
Mhm.
ventricles, these clots can travel to any part of the body through systemic circulation,
Mhm.
through carotid arteries, internal carotid artery, they can travel to the brain, through aorta, celiac trunk, and mesenteric artery. It can go to the gut, cause acute mesenteric ischemia. It can travel to the limbs, iliac arteries, and cause acute limb ischemia. For Plab point of view, these three locations are important. One is acute, one is gut, which will result in acute mesenteric ischemia. One is limb, which will result in acute limb ischemia. And one is brain, which will result in stroke.
Thank you.
So stroke without atrial fibrillation, what are the long-term medications? Anyone?
Statins and clopidogrel.
Yes, that's right. And stroke with atrial fibrillation?
Then direct acting anticoagulants, warfarin or direct acting anticoagulants plus statins.
Yes. According to recent NICE guidelines, direct oral anticoagulants are preferred over warfarin. So if in the MCQs both of them are given in the options, then you will select direct acting oral anticoagulants. Direct acting oral anticoagulants are contraindicated in pregnancy and in renal failure. So except in these two conditions, in all other conditions, direct acting oral anticoagulants are preferred. So the initial management of ischemic stroke if the patient present within 4.5 hours is altiplase. To sum up the management of ischemic stroke, if presenting with less than 4.5 hours, then altiplase, and after that 300 mg discipline for 2 weeks and clopidogrel for life. Carotid endarterectomy is also an intervention for secondary prevention in ischemic stroke. Carotid endarterectomy is basically the surgical removal of the thrombus. What are the indications for carotid endarterectomy? Carotid duplex or carotid ultrasound or carotid Doppler ultrasound of carotid arteries is done in patient of strokes to see if there's as we have already discussed that the stroke can be due to a traveling thrombus from the heart. In that condition, there will be associated atrial fibrillation. But in a patient without atrial fibrillation, the stroke is caused by thrombus formation in the carotid arteries. So the extent of thrombus formation in the carotid arteries is seen by carotid Doppler or carotid duplex. So what is the criteria for carotid endarterectomy? If the stenosis is more than 50% in men and more than 70% in women, then carotid endarterectomy need to be performed within 2 weeks of admission for a secondary prevention of ischemic stroke. The other management of ischemic stroke include low salt and fat diet, quit alcohol and smoking, and weight loss. So a patient, now let's do an example. A patient had slurred speech for 5 minutes. He has hypertension and he takes medication for it. His ECG is normal with heart rate of 80 beats per minute. He is otherwise well. What is the long-term medication for this patient?
Clopidogrel and statins.
Yes, clopidogrel and statins. Statins need to be given to all patients with a history of stroke or terminal ischemic attack. Initially, we give aspirin 300 mg for 2 weeks. Then we start clopidogrel 75 mg lifelong. Now, example number 2, an elderly female with no significant past medical history presented to accident and emergency with speech disturbances and asymmetric weakness of face and arm. This symptom started 3 hours ago. A CT scan of the head shows no hemorrhage. What will be the management of this patient? What is the next best step in the management of this patient?
LD plays.
Yes, as the symptoms onset
With
is the symptoms started 3 hours ago, so this patient is a candidate for LD place. So this was all about stroke and its management. Is there any question up till now? Stroke can also lead to Broca's or Wernicke's aphasia. Broca's area is present in the frontal lobe, while Wernicke's area is present in the temporal lobe. Broca's aphasia means broken speech. The area of the brain that controls the motor speech is located in the frontal lobe, which is called Broca's area, and damage to this area result in a broken speech. The patient has a problem in speech production. He is unable to produce normal speech, non-fluent slow speech. Patients are usually aware of what they are saying. They know that they have a problem with their speech. So in short, what is Broca's aphasia? Broken speech plus good comprehension. Broken speech, and the patient is aware of his condition. On the other hand, Wernicke's aphasia. In Wernicke's aphasia, patient comprehension or understanding is disturbed. Although the speech is fluent, but patients are unaware of what they are saying. They usually produce sentences that do not make sense, but the patient are not aware of what they are saying. So cerebral stroke can result in Broca's or Wernicke's aphasia. What are the other features of cerebral stroke? Remember that the motor control of the body or the muscle control of the body, all the skeletal muscles in the body are controlled by the area which is present in the frontal lobe of the cerebral cortex or in the precentral gyrus. The motor area of the body is located, and all the sensory functions of the body or all the sensations are received in the parietal lobe of the body. So frontal lobe control the movement of the body, and parietal lobe control the or receive sensations from all the body: touch sensation, temperature sensation, and pain sensation. Occipital lobe is associated with vision. Temporal lobe is related with language comprehension and memory formation. So there are 4 lobes of the cerebral cortex: frontal lobe, parietal lobe, occipital lobe, and temporal lobe. Frontal lobe control the movement of the body. Parietal lobe, sensation of the body. Occipital lobe is associated with vision, and temporal lobe is associated with language comprehension. So a cerebral stroke will result in hemiparesis. What is hemiparesis? Weakness of the half side of the body, because as I already told you that the motor control or movement are controlled by the cerebral cortex or frontal lobe of the cerebral cortex. So a cerebral stroke can result in hemiparesis or weakness of half side of the body, and sensation are also controlled by the cerebral cortex and the parietal lobe. So it can also result in the hemisensory loss. And if there is stroke of occipital lobe, then it can result in visual problems. And if there is problem with temporal lobe, that it can cause Wernicke's aphasia. So from these signs and symptoms, we can tell that the lesion is at the level of cerebral cortex. Now, below the cerebral cortex lies the brainstem. How you can identify a brainstem lesion? Remember that there are 12 cranial nerves, 10 of which arises from brainstem. Brainstem is a part of brain which consists of three parts: midbrain, pons, and medulla. So out of 12 cranial nerves, 10 arises from the brainstem. First two cranial nerves, which are olfactory and optic nerve, they have their origin in the cerebral cortex, while remaining 10 cranial nerves, they originate from brainstem. Cranial nerve 3 and 4 originates from midbrain. 5, 6, 7, and 8 they originate from pons. 9, 10, 11, and 12 they originate from medulla. So remember the rule of 2, 2, 4, 4. 2 from cerebral cortex, 2 from midbrain, 4 from pons, and 4 from medulla. The first two from cerebral cortex, olfactory and optic nerve. Third and fourth from midbrain. Fifth, sixth, 7, and 8 from pons. 9, 10, 11, and 12 from medulla. Now, what are the functions of these different cranial nerves? Olfactory nerve and optic nerve, they are associated with cerebral cortex. The function of olfactory nerve is olfaction or sense of smell, and optic nerve is associated with vision. We will discuss the nerves that originates from the brainstem. So the first two nerves that originate from the brainstem, the first part of the brainstem is midbrain, from where oculomotor nerve and trochlear nerve originates. Now, what is the function of oculomotor nerve? Oculomotor nerve, remember the three functions of oculomotor nerve. oculomotor nerve, it's a cranial nerve, third cranial nerve, and it also has three areas of supply. Remember that all the extraocular muscles of the eye are supplied by oculomotor nerve except two muscles. One is lateral rectus and one is superior oblique. Except these two muscles, all the extraocular muscles of the eye is supplied by oculomotor nerve. The second muscles that is supplied by the oculomotor nerve is levator palpebrae superioris. Levator palpebrae superioris. Just focus on its name. Levator. Levator means it elevates the palpebrae eyelid superioris. So it supplies the levator muscles of the superior eyelid. And the third thing is that it carries parasympathetic fibers to the pupil. So what are the three areas of supply of oculomotor nerve? One is all the extraocular muscles of the eye, except lateral rectus and superior oblique, plus levator palpebrae superioris, levator of the superior eyelid, and plus parasympathetic supply to the pupils. So the parasympathetic supply to the pupil will result in the constriction of the pupil. Now, what will happen if there is a lesion or if there is a damage to the oculomotor nerve? All the muscles or all the supply that is given by the cranial nerve 3, the muscles that are supplied by the cranial nerve 3 will be paralyzed. So the first thing that you need to remember for the lesion of cranial nerve 3 is that eye will turn down and out because of the unopposed action of lateral rectus and superior oblique. Because all the other muscles are paralyzed and there is no muscles to oppose the action of lateral rectus. Lateral rectus moves the eyes outward and superior oblique moves the eyes downward. So a down and out eye plus ptosis, because levator palpebrae superioris is also supplied by oculomotor nerve. So in case of damage to the oculomotor nerve, there will be ptosis or drooping of the eyelid, upper eyelid, and also parasympathetic supply is also damaged. So mydriasis will result because of the unopposed action of sympathetic supply. So I hope the function of oculomotor nerve and its lesion is clear to everyone.
Sir, mydriasis is dilatation of the pupil.
Yes,
Okay.
oculomotor nerve supplies the parasympathetic nerves to pupil. The normal function of parasympathetic nerve is pupillary constriction. Any other question? Now the second nerve that originates from the midbrain is trochlear nerve. Trochlear nerve supplies the superior oblique muscle. Superior oblique muscle move the eyes downward. The function of the superior oblique muscle is that it move the eye downward. So whenever there is a lesion of trochlear nerve or cranial nerve 4, the eye will be unable to look downward. So the first two nerves that originate from the midbrain were oculomotor nerve and trochlear nerve. Now, if someone present to you with hemiparesis or hemiplegia with sign and symptoms of trochlear nerve or oculomotor nerve, then you can say that the infarct or the lesion is at the level of midbrain. Now the next four nerves, trigeminal, cranial nerve 5, abduction, cranial nerve 6, facial, cranial nerve 7, and vestibulocochlear, cranial nerve 8. They arise from the pons. What is the function of trigeminal nerve? Trigeminal nerve is a sensory nerve. Remember that the sensation from the face, pain and temperature sensation they are brought from the face to the brain through trigeminal nerve. And also they form the afferent limb of corneal reflex.